You are listening to the Haig MD channel. Nothing on this channel is medical advice. It is for information purposes only, and before you make any changes, or if you need advice, call your own doctor. Hi, Melissa Haig here with the Haig MD channel, and today's sexual health hint is lubrication. Early and often, maybe, maybe not. Remember, some of the lubricants that are out there include lots of different chemicals that can cause massive irritation. So if you have any kind of thinning of the skin or skin conditions, or you're over the age of, say, 35, 40, maybe stay away from the heating, scented, supposed to make everything better lubrications, because I have seen some pretty crazy angry vaginas coming in after that. Okay, so moving on. Today we are going to talk about estrogen. Now, just like we say at the beginning of this episode, none of this is medical advice. These are just some general principles, some things to know, things to think about. This episode for some of you is going to be like way too much information, more than you ever wanted to know. And for others, you're going to walk away feeling like that was pretty basic. And that is because we all have a different level of education when it comes to hormones. So what is estrogen? Well, there are actually several different kinds of estrogen. When we say estrogen, most often we are really speaking about estradiol, or E2, as we would say in the chemical world. And that's an estrogen that has two OHs, or hydroxys, at the end of the chemical makeup. It is the most common one that is used in hormone replacement therapy. It is the most common estrogen in a reproductive age female's body. It is responsible for a lot of different things, which we will go into later. But let's start with who might want to have extra estrogen, like in the form of hormone replacement therapy. I am getting so many phone calls these days for hormone replacement therapy, and women in their 20s calling saying, I think I might need some estrogen because my joints ache. There are a lot of misnomers out there about what estrogen does and does not do, and what it is and is not responsible for. So first of all, just some basic definitions. If you are on any kind of hormone already, just know you should not necessarily have your hormones checked. And what I mean by that is I'll have women that are on birth control pills calling saying, I think my hormones are a mess and I want to have them checked. Well, we don't check hormones in women that are on birth control pills. You would have to go off of the pill because that is a hormone. Most pills contain both estradiol and some form of progestin. So you're throwing hormones into the system. Some birth control pills are just progestin, but either way, when you think your hormones might be off on a birth control pill, just realize you are adding hormones to the system. So the woman that calls that I would say we should probably check and see where you are is maybe mid to late 40s, having some sleep disturbance, maybe some night sweats, hot flushes occasionally, in general, not quite herself, and possibly, most likely, not having regular cycles. And what I mean by that is maybe she still has 10 to 12 cycles in a year, but they are not her classic 28 days apart. She'll have one, and then she'll have an episode of bleeding, and then 35 days later she has a cycle, and then 20 days after that. And I tell women, you cannot think of menopause like a light switch. You have to think of it like a dimmer switch controlled by a gremlin. So some days it's up and some days it's down, and other days it's just fine. And that's why the symptoms really come and go. It's not a constant system. That ovary and brain that had to learn to speak to each other when you were a teenager, and then they kind of coasted along for a while. Well, now they're kind of losing their communication again, and the brain is yelling louder and louder at the ovary, and the ovary is listening less and less. So when we are checking hormones in someone that's still menstruating, we are checking on specific days of their cycle, usually somewhere between cycle days 3 and 5, with day 1 being the first day of your period. Now, in someone who's not having cycles at all, maybe they stopped 3, 4, 5 months ago, we can just check a random lab and kind of see where things are. And what we're looking at is a lot of different things, but for hormones, we're primarily looking at FSH, which is the hormone the brain sends to the ovaries to say, hey, get up, let's start working on ovulation. And then estradiol, which is kind of the ovarian response to that, to see where we are with that. A lot of times I will also check things like thyroid if it hasn't been checked recently, and a prolactin, which is a hormone that you make when you're breastfeeding, but it can also just kind of randomly be made and go haywire. We also check things like a hemoglobin A1C, because as we've talked about on this channel before, insulin resistance can certainly cause the same sort of symptoms that a low estradiol can cause. So we want to see where you are in that spectrum, along with a glucose and a fasting insulin. When we get those labs back, I look at them and kind of sit down and talk with the patient. The first thing I want to know is, well, what are you trying to accomplish? Because keep in mind, if you are 45, no amount of estradiol is going to make you feel like you're 20. So we have to have good expectations of where we want this to head. Like we talked about in the progesterone episode, if we're just trying to address sleep, we might just start with progesterone. And by the way, if you decide I am someone that needs estradiol and you and your provider come to a consensus and you start something, if you have a uterus, you cannot be on estrogen alone, because estrogen is going to stimulate the lining of the uterus. Progesterone is going to stabilize it. Without something to stabilize that lining to kind of counter those estrogenic effects, your lining can go crazy, and you can, besides the fact that you will bleed nonstop and hate your life for that reason, you can cause abnormal cells in the lining of the uterus that could be precancerous or cancerous over a period of time. So if you are on estrogen and you have a uterus, you need to have some form of progestin. Some women will use a progestin-containing IUD for that. Other women will do an oral form of progestin. There's lots of different options, but just keep that in mind. Other things that we want to think about when we are first talking about whether or not a woman is a candidate to start hormone replacement therapy in the form of an estrogen is, does she have any contraindications to that? And again, this is not all encompassing. You need to know your own medical history and talk to someone specifically, but general principles are, if you have had an estrogen receptor dependent cancer, most providers would tell you starting on estrogen is not a good idea for you. There is some data out there to support that it can increase your risk of recurrence of cancer. Now, there's a lot of European data on using testosterone in that population. So just keep in mind, you aren't necessarily left out in the woods, so to speak, or on the hot sun, in the beach, in the desert, depending on the day and how you're feeling. You have options, but make sure you talk to someone that knows a lot about hormone replacement therapy and cancers and what you should and shouldn't be doing. Anyone that has a history of a blood clotting disorder should not be on oral estrogen. Now, transdermal estrogens are significantly safer. And when I say safer, I mean they may or may not be completely safe from the standpoint of blood clotting, but I have patients that come in that say, yeah, I know I'm at increased risk. I cannot live this way. I am miserable. And to be fair, any estrogen that we put her on is still going to be less than what her own ovaries were making when she was younger. But we do tend to be very careful with ladies in that camp. Also, anyone that's had a history of an embolic stroke, meaning a blood clot that caused a stroke. Hypertension that is not controlled, bad idea to just throw estrogen on that. And again, you need to distinguish between oral estrogen and transdermal estrogen, because a lot of the potential bad effects with estradiol can be skipped if you go to a transdermal method, such as a patch or a gel that gets absorbed through your skin, because it is metabolized differently in the body and it reduces some of those risks. So what are the positive things that estrogen can do? Well, anyone like myself who has gone through menopause, in my case very early, can tell you it can save your life or maybe just the lives of the people around you, because it can do a lot as far as sleep and mood and temperature stability in the form of hot flushes, and just create a general feeling of well-being. As far as medical things, definitely can help protect you against colon cancer. That's been well established. Or the converse, if you have a lack of estradiol early in life, you may have a higher risk of colon cancer, depending on what study you're looking at. Perhaps lower your risk of cardiovascular disease if you're on estradiol. The breast cancer thing is the big thing that everybody worries about. I cannot tell you how many patients come in and say, well, I can't be on estrogen because my great aunt, third removed, had breast cancer. That is not a contraindication to being on estrogen. Again, if you have a specific gene that predisposes you or something else going on in your history, maybe you shouldn't be on estrogen. However, most women don't have that kind of history and can safely be on some estrogen, even if it's just a low dose to help them live through those menopausal type symptoms. Other things you should know about estrogen is I have some women come in that are menopausal chemically, meaning they had lymphoma and were put on high doses of chemotherapy that killed the ovarian function. Maybe just temporarily, but maybe longer than temporary. Those women absolutely should be on estradiol, especially if they're younger, without any other contraindications. So a lady that comes in her 30s, she had leukemia and was on chemotherapy for that. If you don't put her on estradiol, she has a higher risk of things like cardiovascular disease, osteoporosis, and colon cancer, as well as decreasing sexual function over time. So those are ladies that absolutely, I like to see them at the beginning of their treatment, and we start talking about when it would be appropriate to start estradiol therapy. Sometimes we need to wait until they are through some of their chemotherapy or all of it before we start hormones, again, depending on what they're on, because of the blood clotting risk, not because it will increase their risk of their lymphoma or leukemia coming back or getting worse, because those are two different kinds of cancer. The other thing to know about is estradiol is available in a lot of different forms. So when I have women come in that say, I only want bioidentical progesterone, or I only want bioidentical estradiol, just realize there are bioidentical estradiols that come as a patch or a pill or a gel. A lot of women mean they want compounded hormones when they come and say they want bioidentical. And those may or may not even be the same thing, as not all compounded hormones are bioidentical. And does that matter? It depends on who you ask. This whole hormone thing is quite the religion. And there are some really strong opinions about it on either side. I will tell you, as someone who has treated women with hormones for more than 15 years, it just depends. It depends on the patient, and each patient needs a hormone regimen that is really specific to her and what's going on in her situation. I've had women that started on a bioidentical progesterone and they were miserable. They felt awful. We took them off of it and switched to some other form, like a progestin, and they felt significantly better. Now, progestins are getting a bad name right now. Are they increasing the risk of breast cancer? I think the jury's still out on that, but it does seem like there is some newer literature that may point to that. So there may be more on that to come in the future. But the point is, you have to look at hormone replacement therapy more as a journey than a destination. Because what we start with may not be what you need for the rest of your life, and may not even be good for you at the beginning. So when we start hormones in our office, I tend to, if you have a uterus and you're peri or postmenopausal, we start with progesterone, because again, we got to protect that uterine lining anyway. And some women do just fine with what we call monotherapy with progesterone, meaning just that hormone. They feel so much better, they really don't feel like they need anything else. If after a few weeks they've been on that and they're feeling fine on it, but we haven't resolved the symptoms that they're wanting to resolve, then we'll add estradiol. Once they've been on that for several weeks, if they feel like they're still lacking with libido or with energy or motivation, sometimes we will add testosterone after we check some blood levels. Now, keep in mind, testosterone and estradiol in your body can go one way or the other. Meaning, if I give you testosterone, you may get a little bit of conversion into estradiol. If I give you estradiol, you will probably get some conversion into testosterone. So if you're on one hormone or the other, I tend to check levels before we decide what to add or how much you need. And then keep in mind, there's a lot of places now doing things like pelleting, injections, and things like that. That can be the right answer for some patients. However, when you pellet or do an injection, just realize whatever dose of hormone you do at that time, you are stuck with until it is gone. So your body has to metabolize that pellet and you will be stuck with it for several months. So if testosterone is something that you're doing and you overshoot, you may be really irritated with acne and excess hair growth, and in some cases even deepening your voice or causing what we call clitoromegaly, where that part of the body gets bigger. Some of those things will stop or reverse as the testosterone is metabolized. Some of them may not. So just be very careful with putting things in that you're stuck with, and make sure that you're seeing a practitioner that understands hormone replacement therapy. Not every OBGYN likes hormones. I'll just start there. If as a physician you don't like something, you tend tend to maybe not know as much about it or not really enjoy prescribing it. And that's okay. There are certain aspects of OBGYN that I don't love, and I let other people do them. So when it comes to hormone therapy, if you're trying to decide, is this something I'm going to talk to my family doctor about or my OBGYN about, perhaps one of the best questions to ask that provider is, hey, do you like prescribing hormones? Is that something you're interested in? Is that something that you do research on? And if the answer is no, then ask them who does and who they would recommend that you see. Some of them will have a one-size-fits-all approach, and that seems to work for them. It really hasn't worked in my experience. So again, I would highly recommend you consider seeing somebody that likes it and that can kind of tell you where they got their education or what kinds of things they look at when it comes to hormone replacement therapy. My education started at the International Society for the Study of Women's Sexual Health when I was doing my sexual health fellowship training. And as I was doing that, I of course came across more and more things that we use hormones for. So back to estradiol, for example, it can be injected, it can be a pellet, it can be a patch, it can be a gel. Then, and that's all the systemic applications. Then you go to the vaginal estradiol. Well, that can be a ring, kind of looks like a ponytail holder that you put in and it stays there for 3 months. It can be a suppository or like a little thing that looks like a BB. It can be a cream. It can be an ointment. There are just so many different options. And then it could be estradiol or estrone or estriol. There are just tons of different ways that estrogen or estradiol is utilized. And some patients tolerate some things great and some patients don't. So when it comes to estrogen, estradiol, hormone replacement therapy, in general, a rule of thumb is if your periods are regular, you are not as likely to need estrogen. Maybe progesterone, like we talked about in that episode, but not as likely to need a form of estrogen. If your cycles are starting to space out or you have a chemical reason for your hormones to be off, such as chemotherapy, that might be something you really want to look into. So that's what I have to say about estrogen this episode. I am sure this is going to generate questions, controversies. You're wrong. That's amazing. Post it in the chat if you want, or contact me with your questions, those of you that know me well. The challenge of the week. So I will tell you, I have definitely fallen off the no sugar train. I can't find my way back to the station. I'm trying, but it's been a lot. I've had a lot going on, and sugar just makes me feel a little better in the moment. However, what I have noticed is my joints are more tender and I don't want to get out of bed as much as I used to. So it's causing other issues. So here's what I'm going to do. I'm going to get through an amazing weekend with my friends and family and frankly, probably not pay as much attention. But then starting after this weekend, I am going to go back to no sugar more than twice a week. So I like twice a week. I think it's okay to have something small. But other than that, that's my challenge for the next week for myself and something for you to consider. So as always, love out loud and live on purpose.